It's my pleasure to discuss various controversies in the diagnosis and management of ISS, with thanks to the Human Growth Foundation for the opportunity to do so. The agenda of this talk is here. I will first define and sub-classify ISS, have several slides on the spontaneous growth of children with ISS, then talk about diagnostic approach of the short child, ethical issues regarding its management, and finally, efficacy and safety of the various therapeutic options. So what is the usual classification of growth disorders according to etiology? I think a useful classification is primary disorders that are thought to be within the growth plate, secondary disorders that have an influence on the growth plate from outside the growth plate. And if we don't know in medicine, we like to use the word idiopathic. So idiopathic short stature is short and we don't know why. Now at the KICS meeting in 1995, there was a long discussion of an expert panel on this idiopathic short stature, because that was a time that a lot of different words were used actually for about the same thing. And then we also discussed that it would be useful to sub-classify ISS in familial and non-familial ISS. And at that time was further decided to sub-classify both with normal pubertal onset or with delayed pubertal onset. At a later consensus meeting in 2007, the participants thought that it was easier to use bone age, but I think it's important to note that a late puberty is not identical to a delayed bone age. There are children with a delayed bone age who are not late in puberty and vice versa. So this is a complicated area that I will not discuss at this time, but I think it's noteworthy that the non-familial ISS with delayed pubertal onset is about the same as what has been called for a long time constitutional delay of growth and puberty, or if you use bone age, maturation instead of puberty. So the definition of ISS, yeah, the child has to be short, and the usual statistical limit is -2 SDS for age and sex on appropriate reference charts. But one could ask, what is an appropriate reference chart? For example, should one use national reference or the global standard proposed by WHO? If you do that in Indonesia, it has been done for a long time on WHO standard. And then you would see that about 35% of the children is stunted. And if you use your national reference, it's of course about 2 to 3%. One could also ask if it is useful to use ethnicity-specific references within a country. For example, in the Netherlands, children of Turkish and Moroccan origin are about 5 centimeters shorter than the Dutch origin children, and adult height was even 10 centimeters shorter. So in Holland, we decided at some point to use separate charts, separate reference charts indeed, for Moroccan and Turkish origin children. And then idiopathic, unknown etiology. That of course depends on the physician's training and the availabilities of testing in the hospital. Normal birth size, that means normal birth weight and birth length. Which reference to use? There are many. How well is gestational age documented? Birth length is often not available. So yes, every part of the definition had its own problems. No abnormal findings in medical history and physical exam and lab screening. Of course, this is dependent on the quality of diagnostic workup. Normal body proportions and no major or no dysmorphic features. So you can say isolated short stature. But therefore, it's very important to measure, of course, head circumference, but also sitting height and arm span. So how should one then call the disproportionate or dysmorphic short child of unknown origin? According to the definition, you rather not use actually ISS, but my proposition would be to use idiopathic syndromic short stature, something like that, until a real diagnosis is made. Because that is important to note. ISS is a sort of non-diagnosis. It is that we don't know actually what the diagnosis is. With regards to birth size, I would like to show you this slide of a large number of children from Tübingen, Germany, with short stature, a sort of isolated non-syndromic short stature. Now you can see there, this is one population. This is a regression of birth length and birth weight. And you can see here that the difference between ISS and STA is actually very arbitrary. It's actually one population. You can also see at the left side that also in so-called idiopathic short stature, average birth weight and birth length is below 0. It's about -1. So the whole distribution of short children is shifted to the left in terms of birth weight and birth length. So then about the sub-classification of ISS into familial and non-familial. 80% of height is thought to be explained by genetics. So it makes sense to make a sub-classification based on the distance to some indicator of mid-parental height. There are different equations for target height, but still the unadjusted mid-parental height, according to Jim Tanner, is still used most. In my opinion, it's better to use the conditional target height. That is 0.72 times the mid-parental height. And that is because it's adjusted for the correlation between paternal and maternal height, so-called assortative mating, and adjusted for the correlation between children's height SDS and mid-parental height SDS. If you use that equation, 95% of healthy children have a height SDS of the conditional target height SDS plus or minus 1.6. So that is the sort of CTH range. So if one looks at familial ISS, so within the target range, probably the cause of most cases is polygenic. So an accumulation of multiple variants, each with a small negative effect on height. However, there are now several studies that did genetic studies in familial ISS, and they found monogenic, often monogenic actually, and in some cases also digenic and oligogenic origin. In the past, familial ISS was a stop of investigations. I think at the present time, it should not be a stop, but you should actually look for some genetic cause. Non-familial ISS, so that's a height SDS lower than this target range, is statistically probably often a slow tempo of growth and maturation in terms of bone age and pubertal onset. So if bone age is not so delayed, and if there's no positive family history for delayed puberty, one should still consider a recessive or novel de novo pathogenic variant or copy number variant, or digenic or oligogenic origin. And if one parent is short and the other tall, so that the target height is still rather high, still consider a dominant monogenic disorder inherited from the short parent. So my advice would be to not only calculate target height or conditional target height, but also calculate paternal SDS and maternal height SDS separately as well. So are there controversies regarding definitions? One would think there should not be any controversies, because There is this first expert meeting with a sort of consensus. There is the international classification of pediatric endocrine diagnosis, which is online for everybody to see. International consensus meeting in 2007, multiple reviews and book chapters in this same direction. But if one reads the literature, there is a wide non-consensus. Some consider FSS and constitutional delay as conditions separate from ISS instead of part of ISS. There's still the debate whether bone age delay or age at pubertal onset should be used. Some use constitutional delay of growth and puberty in the absence of data on pubertal onset, which would be a little strange. And some subcategorize short stature based on height velocity, etc., etc. So there's still an enormous confusion in the literature. Okay, let's go on to the spontaneous growth. There's not much data on that. There's an old paper of ours on a large number of idiopathic short stature children from Europe. And you see here at the left side this mean curve of ISS patients. They start already low, as I just mentioned. Minus 0.8 is their average birth length. In young childhood, they are about minus 1.8. In late adolescence, they get down to minus 2.7, and then they end up at about minus 1.5. There is some difference between the familial and the non-familial. The non-familial is a little bit shorter than the familial line. Now, if you look at this, then you see that it makes a difference if it is familial or non-familial. You can see that the familial ISS ends up only 2 centimeters below the conditional target height. But the non-familial, including, of course, the constitutional delays, they end up 8 to 10 centimeters below target height. So they do not reach their target height on average. And also in an earlier study by Michael Ranke, that was also shown that the adult height in the non-familial ISS is lower than in familial ISS. What was also shown in that study is that the adult height minus the height at onset, at presentation in the clinic, is much larger than in familial ISS. So 1.7 SD is the adult height SDS taller than at presentation. Right, and you also see that adult height minus the predicted adult height was about 0.6 to 0.7 below prediction. So the diagnostic approach of the child with short stature. This is a simplification of the guideline that we made for the Dutch General Pediatrics that we published last year in Hormone Research. We believe that every child that is referred to the pediatrician for short stature and or growth faltering should be seen actually and investigated through a good medical history, family history, physical exam, and an analysis of all the height data that you can get. Then you do also a screening, a lab screening, and an X-ray of the hand. And the new thing is here that we advise not only to do bone age, but also check for anatomical anomalies. From this procedure, you can already get the Turner syndrome as a diagnosis. And if you use a SNP array to check for Turner syndrome, you also get information of any copy number variance or uniparental isodiazomy. You also get from this procedure hypothyroidism and celiac disease. And then it's depending on these diagnostic clues in what direction you continue. If there is more than one or more clue for a primary disorder and the lab is normal, and usually bone age is also normal, there's probably reason to do genetic testing, if of course the height is really short. If there's one or more clue for a secondary disorder or an abnormal lab, for example, a low IGF-1 or a severe bone age delay, specific testing for secondary disorders is indicated. And of course, in others, no clue for any primary or secondary is there, and the lab is normal. And depending on the severity of the short stature, one will proceed again. Now, what has changed over the last 2 decades is that a lot of novel genetic syndromes have been found. And known syndromes have had their expanding phenotypes. Most importantly, actually, in the novel disorders are the heterozygous carriers of variants in genes associated with cartilage formation. For example, SHOX, NPR2, NPCC, ACAN, Indian hedgehog. But also expanding phenotype of established syndromes, for example, those with chromatin modification and RAS-MAP kinase pathway, for example, the genes indicated here, and expanding phenotype and genotype of Silver-Russell syndrome and other disorders associated with abnormal imprinting or methylation. And copy number variants, particularly deletions, are much more frequent than we thought. And then, of course, in the secondary growth disorders, we have a lot of new syndromes in the GH-IGF-1 axis, like the examples shown here. Now, if there are novel disorders, there are novel questions to ask and novel things to look for in the physical examination. And I give you here some examples. So the feeding problems in infancy was probably a question that you asked already, but now there is this link to Silver-Russell, IGF-1R, haploinsufficiency, Noonan, and of course, Prader-Willi as known already. I have, as a young pediatric endocrinologist, never asked for early onset osteoarthritis or discopathy in adult relatives of the patient. But now I think it's a relevant thing to ask because that hints to an ACAN haploinsufficiency. Microcephaly, very important in physical exam because it's a main sign of IGF-1R haploinsufficiency and many other syndromes. Relative macrocephaly, Silver-Russell syndrome, 3M and NF1, and an abnormal sitting height ratio, low arm span height ratio, most skeletal dysplasias. Interesting, there's one exception actually in the skeletal dysplasias in the relationship of legs and arms, because this ACAN patient seemed to have short legs, but rather normal or even long arms. Short upper arms hints to FGFR3, haploinsufficiency, short forearm and lower leg, SHOX and PR2, muscular hypertrophy, SHOX. So there are new things in the medical history, family history, and physical exam to check. On the body proportions, I think this is an important issue. I'm aware that many pediatric endocrinologists are not measuring sitting height, particularly in the United States. I think in Europe, most people use sitting height. The sitting height is probably an accurate, more accurate determination, measure than the lower segment. So the sitting height ratio seems to be a better marker of body disproportion than the upper lower segment. For a long time, there was no American reference available, but I was informed recently that there's a paper in press that offers some sitting height for the US population. So I would like to advise to the US colleagues to leave alone the upper lower segment determinations and go to the sitting height ratio. Arm span minus height or arm span divided by height, that is another interesting marker. There are rare references, and just this year we just published in Hormone Research reference data for a Dutch population, healthy population. It's noteworthy that this is age dependent. So here again, you can also calculate a sort of SDS for arm span divided by height or minus height. And then you can use a clinical score for Silver-Russell syndrome, for example, as indicated here. And we published last year an IGF-1R score. And I would like to say something on that. And you can see here that the low burst size, lower than -1, the short stature, a head circumference below -2, an IGF-1 SDS over 0. And if you have a score of 3 or 4, it gives you a sensitivity of about 76% and a specificity that is acceptable. So you can use actually to select your patients for an IGF-1R genetic determination. We did a similar thing for shocks. There are several of these scores, but now I think it's very important that also patients with the shocks enhancer variants are entered into this population. And that is actually what we did. So we have here postulated that you can test for variants in shocks if either height is below -2 and sitting height SDS is over 1, or arm span more than 3 centimeters below height, or if height is not that short, but there are typical signs, of course, of Léry-Weill syndrome, either at X-ray or at physical exam, or the parent may be short or disproportionate, or have typical signs, and of course, that's also a reason to check for shocks. So we have the idea that with this score, you can also select your patients for shocks determination, which is 2 to 10% probably of your ISS population, according to a lot of studies. One slide on the situation where you have a low IGF-1 and a normal or elevated GH peak. This is in about 30% is this the case. There are people now who would immediately start to do a targeted gene panel. That is one of the possibilities. We have been using in the past this more stepwise approach. So to start with IGF-1 generation test. And if you have a good rise, there are 3 possible known syndromes: neurosecretory dysfunction, bioinactive GH, and a variant in the gene encoding the ghrelin receptor. And if there's no rise, that may be some GH insensitivity syndrome. And there are several genes now, as you know, that are possible. If there's no rise, you can use other lab data to identify your candidate gene. For example, STAT5B would be likely if there's a high prolactin and immunodeficiency. IGF-1 would be likely if BP3 is normal or even at the high side. IGF-ALS, if the BP3 is very low, about -8 or -10 SDS. And activating mutations in STAT3 if there's also some autoimmunity in the syndrome. Now about the ethical issues regarding management. There are an enormous number of papers on the ethical principles in the management or diagnosis and management of children with ISS. But I will here only show you some lines that come from the consensus document published in 2008. The diagnosis and treatment of children with ISS should be under the care of pediatric, under the auspices of pediatric endocrinologists. The child's interest is the primary concern. Define your primary and secondary aims. So is it important for the child to be taller in childhood and adolescence, or is the aim to be taller as an adult? And most importantly, offer an honest and realistic appraisal of treatment expectations regarding height gain, variability of clinical outcome, and possible lack of or possible effect on quality of life. The growth promoting measures should be effective and should take into consideration the risks, benefits, and treatment alternatives, including counseling. And treatment must include continuous and ongoing evaluation of efficacy and safety. Now, regarding GH therapy in ISS, there has been a lot of discussion, and there are arguments pro and contra this form of therapy in ISS. And I would like to list actually those arguments in this slide. So points arguing in favor is that on GH, there's a higher height velocity, there's less height deficit in childhood, adolescence, and mean adult height gain of about 3 to 7 centimeters. Still rather uncertain how much. The treatment can be felt rewarding for the child, parents, and clinician. For each of the three, it's always easier that something is done than if something is not done. The injections are generally well tolerated. There are no significant adverse events, and some children may have insufficient GH secretion. For example, this postulated neurosecretory dysfunction. But there are also points arguing against. So the average effect on adult height is rather modest. I come back to that. And the response is very variable, and it cannot be well predicted. There's uncertainty about the effect of short stature on quality of life and on the effect of treatment on quality of life. It's a form of medicalization, of course. And there is the theoretical risk of long-term sequelae. It's certainly a burden for the health budget. And some people think it's an unacceptable form of cosmetic medicine. So the jury is out, and this is probably also the background that in the US, the points in favor have been felt to be more important. So it's accepted in the US and some other countries, and in Europe and other countries, it is not an accepted therapy for ISS. So what do we have then for treatment options? I think there are 4 things that the clinician can do. If one aims at increasing height velocity and accepts that there is no effect on adult height, testosterone for boys and estrogens for girls with pubertal delay is, I think, a good way to handle it. And oxandrolone has been shown also effective in a little bit younger children in the same way. Then if one aims at augmenting adult height, then of course we have growth hormone. We can think of the combination of growth hormone plus a GnRH analog. One can use aromatase inhibitors, and one can use the combination of growth hormone and aromatase inhibitors. If if the main problem is that the child is stressed by being so short, one can also aim at alleviating psychological stress by psychosocial interventions to support the adaptation process to short stature and to enhance personal resources for coping with stress experiences. And of course, the other thing that one can do is reassurance that there is no pathological cause that can be found, that in principle, the follow-up is normal, and that in general, short people are as happy as other people. So let's look at the various sorts of options. First on recombinant human growth hormone. In the first year, I think it's very certain that height velocity increases on average. The average increase is about 4 centimeters per year. So it goes from maybe 3.5 centimeters to about 7.5 centimeters or 8. I mentioned already the adult height gain, 3.7 to 7.0 centimeters in the first study. Here's the study of Leszek. Here's the study by Hintz. This was about 7 centimeters. This placebo-controlled study was 3.7 centimeters. But there was a systematic review by Deodati and Cianfarani in 2011, where on the basis of all published studies, they thought that the adult height gain versus controls was only 3 to 4 centimeters. However, there is, in my view, an adult height gain that is dose dependent. At the left side, you see a dose response study that we did in Europe, in a large European consortium. And you can see that on this high dose, which is about the Turner syndrome dose, you can see that all children reached a final height within the normal range. And in the lower dose, it did not. And a similar result is shown for the Swedish study by Albertson Wickland, where an even higher doses was effective in having the children a height on the mid-parental height. So dose is dependent, is important. And in my view, on a high dose, 7 centimeter is probably also yes, a good estimate. So are there predictors of adult height gain? There are several studies on that, but not that many. And the ones that I picked up are the following. So a lower age at start and a higher first-year responsiveness comes out of the paper by Dr. Reinke on the KICS database. Higher birth weight seems to be more effective. Lower baseline IGF-1 and more IGF-1 increase during treatment. Higher dose, as I just mentioned, and more bone age delay. And on that last one, I would like to show you one slide of a study that we did in Europe, where on the y-axis you see the final height minus predicted adult height, and this line here are the untreated controls. So you can see that if bone age delay is very long, that final height minus predicted height gets negative. And if it's short, the final height is a bit higher than predicted adult height. And you can see here on the high dose, that is this line, that particularly the gain is made actually in the children with a long bone age delay. Then about the combination, human growth hormone plus GnRH analog. That's an interesting study by Dr. Pasquino in 2000, JCM from Rome, Italy. These are short normal girls with a low predicted adult height. And you can see the predicted height at start was only 146, 145 centimeters. And with the combination, they reached an adult height of 156, so 10 centimeters taller. In comparison to GH alone, where it is about 6 centimeters. And interesting, they have a height SDS for bone age here that is even higher than at start, while on GH alone, it is exactly the same as before. And you can also see that the children on the combination are taller than their target height, while that is not the case with GH alone. So this is a rather strong argument, but you should note that the duration of this therapy was actually very long. It was almost 5 years, which is probably longer than people would like to really retard puberty. In the Netherlands, we also did a study, but that was on 3 years combination versus untreated controls. And we had adult height data on 32 patients. Here are some data. You see that the final height or adult height is a little bit higher than in the controls. The final height minus height at start is also higher. You can see that the prediction after 3 years was 9 centimeters higher, which was lost in the years after stopping therapy. But there was still, in the end, a final height that was 5 centimeters taller than the initial prediction. But most importantly, you see an enormous difference between boys and girls here, because here you see a very nice effect on final height minus target height in the girls. They almost reach their target height, while there's no effect in boys. So here the result is an adult height gain in girls of almost 9 centimeters and no effect in boys. How about aromatase inhibitors? The first study that was done with an aromatase inhibitor in children with a short stature was the study by Wickman in 2001, published in Lancet, with a follow-up, Dr. Hero in 2006. And here you see the baseline data. These were rather old adolescents, 15 years, bone age delay, a documented pubertal delay, as you can see. They were about -2 height SDS at start. And unfortunately, the randomization procedure did not result in an equal target height and predicted adult height. And you see it's almost 4 centimeters or 3.5 centimeters difference. What was the near adult height after 1 year? 175.8 in letrozole, treated children, 169.1 in the placebo controlled, and also the delta was larger. And if you look at this nice figure, I think a lot of readers have thought this is a very nice therapy, very successful. But I have some comments that makes it a little bit less persuasive. In the first place, there is a design problem in this study, which is not very strange because it was the very first study to do. They added testosterone because they thought it's needed, but only the letrozole alone will already lead to a high serum testosterone. So they stopped after 6 months, the extra testosterone. Testosterone alone would increase, of course, height velocity more than the aromatase inhibitors, which would have a psychological advantage for testosterone therapy. And as I mentioned, there's a selection bias. The letrozoles are taller with regards to height SDS, target height, and predicted adult height. I calculated the adult height minus target height, which is -1.3 versus -4.8, which is a difference of 3.5 centimeters, of course. But unfortunately, no real adult height data are reported. This is still a group with bone age between 15.7 and 18 years. So this is not a real adult height. And these late maturers can continue growing for quite a long time. There's also a study by the same group in ISS young children, young boys again, for 2 years, letrozole versus placebo. Here you see the inclusion, and at baseline, these were 11 years, and the large majority was prepubertal. Here there's no selection bias, and the results were that predicted adult height after therapy increased by 5.9 centimeters after 2 years, and height SDS by 0.7. And you can see very nice results. But again, here there are some problems in the interpretation. Most subjects were prepubertal, about 90%, and 45 were still prepubertal after 2 years. And why would you give an aromatase inhibitor to a prepubertal boy? His testosterone is still very low. What aromatase inhibitors do is to block the conversion to estradiol, But if there's no testosterone, it doesn't make much of a difference to the circulating estradiol. There's an extra reason not to give this drug to prepubertal boys, because they saw at follow-up that particularly the patients who started before or in early puberty had vertebral deformities during follow-up. And at follow-up after 6 years, the difference in predicted adult height, still not adult height, was not significant anymore, but still about 4 centimeters difference. But as I mentioned, no adult height available. And there is another study, the third study, on now on anastrozole or letrozole alone, or GH alone, or the combination by Nelly Moraz, 2016 JCM. And you can see here, nice result, and you see that the combination is more effective in terms of height SDS. It is actually a low bone age advance. You see a little increment of bone age in GH alone, and near final height is shown here. It looks nice, but one should look at the mid-parental height of 171.1 centimeters. And if one really calculates, and I do that here, again, here the problem is no untreated control. So we don't know actually what untreated patients will do, and no real adult height. The predicted adult height at near adult height, so at 17.4 years at a bone age of 15.3 years, percentages is shown here. If you calculate that, then the predicted height, the adult height at that time is 171.0, so equal to the mid-parental height. And the others are lower, of course. It's also important to note that the aromatase inhibitors have a very slow height progression. They have the lowest short-term height gain. And here are the near adult height minus target height data in comparison to the historical controls from the paper by Michael Ranke. And you see, it's not so obvious that they gain. They may gain if indeed historical controls end up 3.3 centimeters below target height. In that case, this combination may give you 3 centimeters, but there is no active control to check. Now, what on safety? Here you see the data on growth hormone. Adverse events are rare and non-severe. Long-term follow-up. Just months ago, we saw a paper of Lars Savendal on the SARCH study that in low-risk patients with isolated GHD or ISS, there is no increased risk of malignancies. The analog of GnRH have some local reactions. It's not too rare. Maybe also weight gain and lower bone mineral density in the study that we performed. The aromatase inhibitors, letrozole had a serum testosterone elevation, which was rather high, and erythrocytosis, an inhibition of the GH-IGF-1 axis, and decrease of serum HDL. And I mentioned already the vertebral deformities. For anastrozole, no significant adverse events were mentioned in the papers by Dr. Moraz. So in conclusion, ladies and gentlemen, let's agree about definition and subcategories, maybe another consensus meeting, but even consensus meetings do not always work. Spontaneous growth, the familial ISS ends up at about target height. Non-familial FSS, about 8 to 10 centimeters less than the conditional target height in males. And I didn't mention that, but about 7 centimeters in females. Testing for genetic causes of short stature will decrease the percentage of ISS in referred children. It's important to comply with ethical principles and provide balanced information. The adult height gain by growth hormone is 3 to 4 centimeters in the systematic review. High dose, perhaps 7 centimeters, but very variable. There's more effect on adult height if the age at start is lower, if the responsiveness in the first year is higher birth weight, lower baseline IGF-1, more IGF-1 increase, more bone age delay, and higher dose. The combination of GnRH analog and growth hormone is probably more efficacious than growth hormone alone in short girls. And the effect of aromatase inhibitors alone or plus recombinant growth hormone on adult height is still uncertain. RCTs, including untreated controls, are needed up to adult height. I'm aware that aromatase inhibitors are being used widely in the world, but I would like to emphasize that there's still no good data to support this. So this is the end, ladies and gentlemen, but I'm sure there's much more genetics and epigenetics to come in the future decades. If you would like to read more on the guideline, here is the reference to the paper of last year. And if you would like to approach me personally, here's my email as well. I thank you very much.
I'd like to begin the discussion by going back to a point you made earlier in your lecture about the use of ethnic specific growth curves. This is a very difficult, complex, and controversial subject. In the United States, the CDC has in fact determined to use a single growth curve regardless of ethnicity, largely based upon the common anthropological observation that families immigrating to the United States in the days when the United States accepted immigrants often caught up within one generation to the average US height standards, that ethnic variations in height were less genetically based than they were based upon nutrition, overall health. Can you comment on that?
Yes, I think in the United States, I think it's a very good idea to have no specific ethnic charts. I think also when you take target height into consideration, you have already also some form of adapting actually to that. If you have short parents and the child is short, then yeah, of course that can still be a sort of genetic abnormality, but it can also be dysethnicity. We decided to do it in the Netherlands because the difference at that time was so large. So it was one standard deviation. So the short Moroccan child was very short for the Dutch. So we thought it was better actually to do it this way. But in 10 years, the Turkish and Moroccan children caught up already 3 centimeters. And I'm sure if we do another study in 10 years more, they will have another 3 years. So there is this adaptation. It's not so fast as one generation, I would think, but it is coming on. So there's no absolute need to do it. I just would like to emphasize that in countries where the height of the population, the general population, is still much shorter than in the rest of the world, like Indonesia, Philippines, Bangladesh, etc., the use of the WHO standard makes so many healthy children stunted, so sick, that has to be done something about. That is, I find, not a very good idea.
One of the attendees in that regard asked the question, rather than using different curves for different ethnic groups, could one not use mid-parental height to take into account the genetic variance of growth within a family?
Yeah, that is actually what I just mentioned. Indeed, if you take midparental height or target height into consideration, then you have already solved the largest part of the problem. Although, of course, your height is first assessed by the public health officials on height per se. Usually they not immediately look also at the parental height. We have been telling the public health departments in the Netherlands to always ask for parental height. But I heard also from the UK, etc., that it's sometimes very difficult to get those data. So it is indeed a good way, actually. You always need actually the target height. So it's very important to always ask for parental height and if possible, measure parental height as well.
Leo Finnegan wrote in, how, when did idiopathic short stature become an accepted diagnosis for growth hormone treatment? And let me preface the response by saying, I'm not sure it is an accepted treatment, but why don't I briefly explain what happened in the US, and then Jan Martin, you can explain what the thinking is in Europe. So the initial controlled trials of growth hormone and idiopathic short stature were performed primarily by Eli Lilly. And when they were considering going to the FDA, they put together an external advisory committee that I participated in together with Mel Grumbach and Ray Hintz and several other people in addition. And I must say that my initial thinking was that I would be opposed to ISS as an FDA-approved indication. But what convinced me to support it was that, number one, the Lilly-controlled data showed an improvement of adult height more in the range of 6 or 7 centimeters, rather than some of the more modest data that Jan Martin has cited. And in addition to that, it reflected my skepticism about growth hormone deficiency testing, that we base a diagnosis on tests with arbitrary levels. And it seemed crazy to me that 2 children who were both minus 2.8 standard deviations in height, one who had a peak growth hormone of 9 and one who had a peak growth hormone of 10.5, one would qualify for growth hormone therapy and one not. So that largely led to the approval by the FDA in what was actually very close to unanimous opinion in the 1990s. Now, Jan Martin, perhaps you can speak about the thinking in Europe.
Yeah, I think there's no general thinking in Europe, but in the EMA, it went in a different way. Of course, it happened a little bit after. And at that time, there was more known also about quality of life studies. And they focused really on in their opinion at EMA, modest increase of adult height, and actually at that time still a few data. And also that it was not convincingly shown that it made any effect or impact on the quality of life. So they highlighted actually very much the quality of life issue. I think it's a very difficult area of the quality of life because people like to adapt to the situation. So if you're short, you adapt to that. And if you're a little bit less short, you adapt to that. So it's very difficult to show an increase or a change in quality of life. So it's still important for us and for the children in our minds, but it's very difficult to document. So in the end, actually, the committee decided not to do it because they found the effect too modest. Actually, the Leszek data, as they published, were 3.7 centimeters. But it was a difficult study, the Leszek, because there was a lot of children who stopped halfway. So the final data are just a small subset of the original study. So it was not a very strong study, in my view. Okay, but that's my my talk about it.
Yeah, Martin, Alex George writes in from Brazil with this question. What is your opinion of performing growth hormone treatment while the child is prepubertal and then suspending the treatment during the growth spurt during puberty in patients with ISS?
Actually, we did a study on that, and I took it out because it would have been too long. But we have done a study where we had growth hormone in a high dose up to the onset of puberty. And they did very well in high SDS, but they did also very fast in bone age, and they did very fast in onset of puberty. And their adult height, and we published also that, also by Dr. Van Gol, that was exactly identical as the untreated controls. But both were happy. The ones who had the treatment were happy because they had done something about it and they did all that they could. And the ones who did not have the injections were happy that they didn't have the injections. So in the end, everybody is happy, but there was no effect on adult height.
Jan Martin, given that so many studies have indicated that we overdiagnose growth hormone deficiency, that perhaps as many as 70% of children who are labeled and treated as growth hormone deficient turn out to not be growth hormone deficient upon retesting. Aren't we, in fact, treating many ISS patients even while we label them as being growth hormone deficient?
That's absolutely so. I think it also depends of if you do priming with sex steroid. There's of course this very long debate, but which will probably never end. And in my opinion, the TH test should aim at to optimize or maximize actually the secretion of growth hormone from the pituitary, and that can only be done, I think, with stimulating it with sex steroids. Now, I know in the United States, there are very few people doing it, as far as I know. And also in Europe, there's a strong division of opinions. And I think it will never end because it will be very difficult to do a very good study with such a result that everybody will believe. So it will be for the next 10 or longer years that we have the same discussion. But this is one of the very important things, particularly the GH deficient patient. Indeed, the isolated GH deficient patient who has no other, and that has also no MRI abnormalities, no genetic abnormalities, 60, 70, 80% of them turn out normal in young adulthood. And my hypothesis is that they were not GH deficient at start as well.
Yeah, Martin, Paul Kaplowitz asks, given the high cost of both growth hormone and GnRH analogs and the modest and, as you described, still unproven effects on adult height, especially in boys, are there any situations where you personally would consider the use of the combination?
Sorry, the combination of aromatase inhibitor and GH or of the analog?
The combination of the two.
Okay. In the young girls who enter into puberty, I think that the paper that I showed by Dr. Pasquino is a rather strong paper. It's on a small number, but it's well done. It's up to adult height. The main problem of the other studies is that they could not really get these people back at the end of in young adulthood, so that you are sure that you have picked up the adult height. That's one problem. The other problem is no untreated controls, or actually in a lot of them, no untreated controls. So we are actually in a mist. But I think her study and our study show rather nicely, I think, that girls with an early or rather early onset, with a low predicted adult height, they gain probably by this combination. We cannot do it in the Netherlands because it's not an accepted indication. But in other countries where there's more possibilities to do actually what the doctor thinks is good, I think this combination would be effective in the girls, in those type of girls. I also do not exclude that a combination in boys of growth hormone and aromatase inhibitors, and particularly anastrozole, would be effective. The problem is we have no data to show that. But it seems like that from the Nelly Moraz study, because they end up at the target height, while on average, ISS ends up lower than target height. But of course, if you have no real hard data to show that, it's just an hypothesis. But we have done it also in some centers in the Netherlands, as far as I know, that aromatase inhibitors are given if you really think something has to be done. So, yeah.
Tessa Lebinger writes in, will treatment with growth hormone or GnRH channel, will treatment with growth hormone, aromatase inhibitor or GnRH analog affect body proportions? Will this be problematic, do you think?
Yeah, I think it will make some changes, but not in a sort of negative way. You see, if you are short, and particularly if you are in early puberty, you get short legs. And if you have this combination of GH and this, for example, analog, then you normalize actually your body proportions and you get taller. So it is actually in the positive side.
Harry Hirsch asks, is there any role for recombinant IGF-1 treatment in ISS? Either
Yes,
by itself or in combination with another agent?
Yes, I looked at the data, and in another version of this talk, I had also a line on IGF-1, but I found the data not convincing enough actually to spend much time about it. Actually, I think the data are not good enough actually to know if it is effective. The side effects are certainly more severe than of all the other medicaments. So at the present time, I would not go for IGF-1 in ISS.
Veronica Marique asks, it's a little bit off topic, but it's an interesting question. What about a short SGA kid who is approaching puberty? Would you, or perhaps having premature puberty, as sometimes occurs, would you be willing to use a combination of growth hormone and a GnRH analog?
Yes, absolutely. And that has been shown actually rather nicely in a paper by Anita Hawkins' team from Rotterdam. It is also not a very placebo-controlled or something like that study, but it's an indirect evidence that SDA patients on GH, if they are short at onset of puberty and you add the analog, they get taller than they would have been if you would not have added the analog. That's the paper of, I think, about 5 years ago of that team. That's the only data there is. And plus, of course, our own data was on ISS and SDA. So there were also children with SDA in that and ISS. And as I mentioned, the division between ISS and SDA in isolated short stature is very arbitrary. I think it's just one patient group.
Okay. Yeah, Martin, the final question, again, somewhat off topic, but you have so much expertise in this area, I'm going to borrow it anyway. Rick Levy asks, do you feel that children with syndromes without a specific approved indication for growth hormone should not be treated? Are there any syndromes that currently do not have FDA or EMA approval and would not certainly fall into the category of ISS because the diagnosis has been made, where you would consider growth hormone, or you feel growth hormone is contraindicated?
Yeah, that's a very important point, and it's not so far out actually of this topic, because of course if you do no testing, every child is idiopathic. that's obvious, right? And I think even that fact that ISS is accepted and some syndromes are not accepted indications has led doctors to not do any genetic testing, because if they would get a syndrome that is not good for an indication, they would not get the hormone. What we have done in the Netherlands now, we have started a committee that the pediatric endocrinologists in the country can propose actually GH therapy for a child with a rare syndrome on the basis of some published evidence. That can be a case report or a few patients, etc., or rational or scientific reasons that it might be well possible. And that committee will decide actually if we can accept that as a group of pediatric endocrinologists in the Netherlands. You can do that also in your own team, of course, and you can look at the data. For example, Alexander George showed that these NPR2, these Indian hedgehog patients do rather well on GH. So it has some data on that. That is for us in the Netherlands reason enough, actually, that if we have this rare patient with Indian hedgehog, that this will be accepted probably by the committee to start them on 1 year to show how he does.
Now, Martin, thank you. We had an enormous turnout for your lecture, and I apologize for not being able to get to all of the questions. It was a fabulous lecture. Many of the issues you've raised about genetic testing for ISS will come up in the next lecture, September 8th, when Andrew Dauber speaks about the genetics of short stature.